Hello, everyone. Guess we'll start in a couple of minutes. I'm not sure if everybody's on yet. Can you all hear me? You can shake your heads or something. Okay, good. Just want to make sure. Okay, well, good afternoon, everyone. Guess we'll get started. Thank you for joining us today for the Interagency Coordinating Council's quarterly meeting. Before we get to this afternoon's agenda, I want to briefly speak a little bit about the annual report and what we learned about the impact of the coronavirus pandemic on our fight against the opioid crisis here in Maryland. As you remember, and I think we talked about it in the last meeting, in 2019, we had good news. It was the first time, or first decline, I should say, in a number of opioid-related deaths in Maryland since the crisis began. We had a 2.5% overall decrease, which brought about a 13% reduction in deaths involving heroin, an 8% decrease in cases that were linked to mixture of heroin and fentanyl. And I think it's easy to argue that our comprehensive approach to education, intervention, treatment, and response to the crisis was working. And then back in March of last year, the pandemic hit Maryland, and COVID-19 claimed lives of, I believe we're up to around 8,000 people now in Maryland and over 500,000 people nationwide. And our daily lives were upended from work at home orders, hospitalization, school shutdowns, and of course the mask requirements. And so the combination of all those stresses, from job loss to health concerns, anxiety, social isolation, took a toll on our physical as well as our emotional health. And particularly those suffering from substance use disorder, it had what it all appears to be a significant increase, or a significant impact, I should say. And so the Maryland Department of Health recorded 2,773 unintentional deaths involving drugs and or alcohol during 2020 calendar year. The data shows a near 17% increase in deaths from drugs and alcohol over the numbers in 2019. And we believe that these increases can be directly attributed to the COVID pandemic. As mentioned before, the stresses associated with isolation and economic distress and housing and food insecurity, jobs insecurity, had a major impact in this area, as well as disruption in treatment and the support systems that are vital to the recovery of many people, and also, played in a role in the increase in fatal overdoses. The data from the health department does tell us, something important, and that is that opioids were involved in 90% of all substance use-related deaths. 2,400 people, over 2,400 people are no longer with us because of opioids, and roughly 2,300 of those deaths involve fentanyl alone. And as most of you know, it only takes a little bit of fentanyl to be deadly. Heroin-related deaths, continue to decline, roughly 25%, which is continuing a trend that dates back to 2017. But it's not really much of consolation considering the sizable increase we've seen with regard to the number of people who've succumbed to fentanyl deaths. So we appreciate the data collection and analysis that's being provided by the Maryland Department of Health, which will help to inform us as we continue to work forward. I do want to say the Opioid Operational Command Center, which leads our coordination of these efforts to identify obstacles to treatment and create opportunities to improve access and resources during this pandemic and beyond. And they've done an excellent job. Right now, the Opioid Operation Command Center is partnering with the Health Department on what's called Data-Informed Overdose Risk Management, or DORM project. The DORM project was created because of requirements within the Health Department to examine prescription and treatment history of individuals who died from opioid and or other controlled substances over the last 4 years or the 4 years preceding their death, get access to overdose risk factors, or assess, I should say, overdose risk factors, and develop programming to target opioid misuse, as well as intervention methods for at-risk individuals, and make recommendations to improve the substance use disorder prevention response, as well as data collection efforts. The administration will continue to be committed to using data to make strategic policy decisions. And I'm confident that the work of the OC for short and Maryland Department of Health will yield information and a depth of analysis that will allow us to address gaps in service as well as engage individuals in a meaningful way. So I look forward to hearing more details with regard to this and other programs from the OC as this meeting continues. Real briefly, this year, the new Racial Disparities Task Force began operating to promote equitable health outcomes within the African American community. The Racial Disparities Task Force is co-chaired by Dr. Aaliyah Jones, who is the Deputy Secretary for Behavioral Health, and Dr. Noel Brathwaite, the Director of the Office of Minority Health and Health Disparities. The task force will be investigating factors that can contribute to racial disparities in overdose data, as well as other health outcomes. They will also, they are also charged with proposing solutions and remedies to the inequities that may occur or they may encounter and find in their work. Dr. Brathwaite will provide us with some details and updates on the progress of the task force and goals and next steps during our meeting in a few minutes. And then lastly, as chair of the Interagency Heroin and Opioid Coordinating Council, I stand behind and with the administration's commitment to assist those struggling with mental health and living with substance use disorder. The pandemic has been an ardent reminder that as times change and circumstances evolve, so must our response to these circumstances, to addiction, to the opioid crisis. It must also evolve. And as we move into or continue in 2021, our hope is to rebuild on the momentum of decreasing drug as well as alcohol-related deaths and increase access to resources in our state by using a data-driven and a holistic approach. So with that said, I'm gonna just take a few minutes to do a roll call. When I do mention your name, if you can just take a moment and introduce yourself and your agency or organization. Since I know that I'm already here, I won't call my name out. Dr. Leah Jones.
Hi, good afternoon. Aaliyah Jones, Deputy Secretary of the Behavioral Health Administration.
Thank you. Superintendent Jones, Woodrow Jones, that is.
Good afternoon. Jerry Jones, Superintendent of the Maryland State Police.
Good afternoon. Secretary Robert Green.
Good afternoon. Robert Green, Secretary of the Department of Public Safety and Correctional Services. Thank you.
Thank you. I understand Jay Cleary is here for Secretary of Ed.
Yes, thank you. This is Jay Cleary, Chief of Staff, here for DJS.
Okay, thank you. And Randy Lithicum is here for Ted Delbridge.
Yes, good afternoon. Randy Linthicum, Director of Emergency Operations at MIMS.
Okay. Russ Strickland, Executive Director Russ Strickland.
Good afternoon. It's Russ Strickland, Executive Director of Maryland Emergency Management Agency.
Thank you, Russ. Gary Barton.
Hi, Gray Barton, Director for the Office of Problem Solving Courts, Maryland Judiciary.
Thank you. Director Shu.
Good afternoon, everyone. Steve Hugh, Executive Director of the Opioid Operational Command Center.
Okay. Martin Hammond, I believe, is here for Executive Director Glenn Houston.
Afternoon, everyone. Marty Hammond, Deputy Director of Criminal Justice Programs for Governor's Office of Crime Prevention, Youth and Victim Services.
Okay. All right. Thank you. Okay. Our next order of business is to get a vote on the approval of the minutes from the last meeting of January 26th. Has everyone had an opportunity to review those minutes? And are there any questions or changes to those minutes? So do we have a motion to approve?
This is Secretary Green. I'll move approval.
Thank you. Do we
And
have
Russ Strickland will second.
Okay. All in favor of the approval, say aye or show an indication.
Aye.
Aye.
Hi.
Aye.
Any dissenters? Okay, so that motion they're approved. I want to turn it over to the Executive Director of the Opioid Operational Command Center, Executive Director Steve Hsu, for a review of the 2020 data and any other updates that he may have. Thank you.
Okay, thank you, Lieutenant Governor Rutherford, and good afternoon, everyone. Thank you for joining us for the call. What I'd like to do is take the next few minutes to drill down on some of the high-level statistics and trends that the Lieutenant Governor mentioned in his opening remarks. We'll ask Michael Corey to pull up our presentation and proceed on to slide 1. As Lieutenant Governor mentioned, the year 2020 was a very difficult one for the state of Maryland. Fatalities from all forms of drug and alcohol increased to 2,773 for the year. That was up almost 17%. This was especially disappointing after 2019, which was the first year in a decade, certainly in the modern era of the substance misuse crisis, that we saw an actual decline in the number of fatalities. Despite this disappointment, however, in the national context, Maryland is doing comparatively well. The CDC recently reported that through August of 2020, fatalities from substance use disorder were up approximately 25%. Turning to the quarterly progression, as the year progressed and as COVID bit deeper and deeper into our society and our way of life, fatalities related to substance use disorder accelerated. In the bottom quarter of the chart, you'll see in dark blue the first quarter of 2019 compared to 2020. There were 648 fatalities in the first quarter of 2020, up 4.5%, a relatively modest increase. But as COVID began to bite in the second quarter, fatalities accelerated to almost 19% in the second quarter, to 22% in the third quarter, and again, 22% in the fourth quarter. Looking at the opioid component of those overall substance use related fatalities, opioid related fatalities were up 18.7% in 2020 to a total of 2,499. As Lieutenant Governor Rutherford pointed out, that's 90%, 90.1% to be exact, of all substance use related fatalities in the state of Maryland. By way of comparison, if you go back to 2015, opioids comprised about 86% of the fatalities in that year. So unfortunately, opioids are taking an ever increasing share of the fatalities overall in the state. Looking at the different opioids that are at play within that larger opioid category, you can see that fentanyl is by far the most common substance of misuse within the opioid category. There were 2,326 fatalities that involved fentanyl during 2020. That's 93% of all opioid-related fatalities and 84% of all substance use-related fatalities overall. Those fatalities of 23-26 were up about 21% from the prior year. Heroin, I don't wish to characterize it as good news, but we certainly hope to see heroin continue what is now 4 years of declines as fentanyl elbows it out of the market. It was down, fatalities related to heroin were down 25% to 543. And I know we all look forward to the day when heroin disappears entirely from Maryland. In terms of prescription opioids, the numbers are relatively smaller, but they're very concerning in their own way. There were 445 fatalities related to prescription opioids like oxycodone during 2020. That was up 21%. This is a reversal of 3 years of declines that we had experienced through 2019. And this is especially concerning because I think we all know that for many people who suffer from substance use disorder, it was prescription opioids that opened that door and set them down that road to substance misuse and addiction. Looking at the individual counties, you'll see a very mixed experience. There were actually 4 counties that experienced a decline in the number of fatalities during 2020: Calvert, Carroll, Garrett, and Kent. So Central Maryland, Southern Maryland, Eastern and Western, all 4 different parts of the state represented by that fortunate group. There was 1 county that was flat for the year, that was Talbot, but 19 were up. So 79% of Maryland counties experienced an increase in fatalities during 2020. And in some cases, they were very, very sharp, including Prince George's, Cecil, Allegheny, Howard, Charles, Worcester, Dorchester, and Somerset, all of which experienced an increase in fatalities of more than 40% compared to 2019. Baltimore City had the highest numerical increase, but was below the state average in terms of the percent increase. We are encouraged by the single-digit rates of increase in Frederick, Hartford, St. Mary's, and the actual decreases in those I just mentioned: Carroll, Calvert, Garrett, and Kent. Looking at things regionally, Western Maryland, which lights up in red, was the hardest hit region of the state, up 46% when taken as a whole. They were followed by the Eastern Shore and the Capital Region at 38% and 32% respectively. Relatively moderate increases in Baltimore City, Baltimore County, Hartford, and declines in Carroll made Central Maryland the least impacted region of the state, collectively going up 12.7%. shown in yellow, and Southern Maryland was not much worse at 14.6%, also showing in yellow on this chart. But when we look at mortality, we see a very different story, except for Western Maryland. Central Maryland remains the hardest hit state, portion of the state, from a mortality perspective at 56.1 deaths per 100,000 population. That's an unfavorable reversal from the prior chart. Baltimore City and Cecil County have traditionally been the number 1 and number 2 in the state. Western Maryland was the second hardest hit region of the state at 45.4 fatalities per 100,000 population. And this region is the only region that was red in this chart and the prior chart. The DC metro region flipped from, as you may recall in the prior slide, light red to light blue, which is not surprising because the Washington metro region has traditionally been the least impacted region of the state by opioids. The nature of the drug markets and consumer patterns or usage patterns are different in the Washington metro region. So we're concerned about the sharp increases during last year, but despite those increases, the overall rate of mortality remains relatively low at 10.7%. There are numerous non-opioid drugs of misuse that are involved in the fatalities in Maryland. The most significant, the most prevalent being cocaine. There were 917 fatalities that involved cocaine during 2020. That represented 33% of all intoxication deaths. And over 90% of cocaine involved deaths involved opioids as well. Alcohol was up 33.1%, benzodiazepines up about 5%, methamphetamine up the sharpest of any category, up 85% off relatively small numbers, but nevertheless something to be very concerned about, and PCP up 24%. When you take the non-opioids as a group, they were involved in 63% of all substance use related fatalities in the state. So opioids are involved in 90% of all fatalities, and these 5 non-opioids are involved in 63%, which I think underscores the prevalence today of polysubstance use, of mixing together multiple compounds. As COVID progressed during the year, we saw disruptions to our system of emergency response. For the year as a whole, emergency department visits were down 11.4% from 2019. And as you look at the chart, you'll see that there were sharp decreases in the first quarter, emergency department visits down 23%, even sharper increases during the second quarter, down almost 30%. And then a reversal in the third quarter, and the number of visits in 2020 actually surpassed 2019 in the fourth quarter. We see some similar anomalies with naloxone administrations. The red line is 2019 and the blue line is 2020. And as you scan from the left toward the right, you'll see that the number of naloxone administrations by emergency medical staff were running substantially below 2019 during 2020, up until about mid-May. And then the lines crossed. And since that time, 2020 has substantially exceeded in most months the number of naloxone administrations in 2020 versus 2019. And when you take it all together, the overall administrations are about flat year over year, despite these unusual patterns. In our annual report, we've started to drill down more deeply into some of the critical demographics. You'll see on the left, breaking the fatalities down by race, there were 1,417 fatalities among white Marylanders. That was up almost 18%. There were 976 fatalities among Black Marylanders, of about 18% also. Hispanic Marylanders, a very sharp increase, off small numbers, but a very sharp increase of 49%. The relationship between Black and white fatalities has reversed from what we had been seeing over the last 3 years, as I'll show you in just a second. Though Black Marylanders are still outpacing white Marylanders by per capita measures. In terms of gender, this breakdown of female to male, 27% to 73%, is consistent with what we've been seeing in the past. Men are much more likely to die from substance use disorder than are women. And finally, from the standpoint of age, you'll see that we've broken down the age cohorts into 5 different categories. If you set aside the under 25 cohort, the number of fatalities across the remaining age cohorts is relatively consistent from age cohort to age cohort, which tells us that this is not a disease of the middle-aged or the young or the old. It's a disease that anyone can get at any age in their life. Turning to the trends that I mentioned within racial categories, if you look at the gray chart, that's white Marylanders, the blue is Black Marylanders, and the purple is Hispanic Marylanders. If you follow that gray line from left to right, you'll see that very sharp increases in fatalities began in 2016 and into 17, but then began to tail off. White Marylanders fatalities declined from 2017 to 2019, almost 12%, going from 1,360 to 1,204. But then we saw that sharp increase a moment ago in 2020 of 18%. Whereas Black Marylanders have followed a much more consistent and steady trajectory from 98 way back in 2011, steady increase to 2015 of 289, and then a sharp increase in 2016 as fentanyl arrived in massive scale on the scene, and steady increases since that time. Between 2017 and 2019, fatalities among Black Marylanders were up 40%. And again, as I mentioned, from 2019 to 20, up another 18% in line with white Marylanders. I'd like to take a moment to provide some additional updates on special projects that our office has been pursuing. 2 weeks ago, we released our annual interagency opioid coordination plan, which outlines the state's framework for responding to the opioid crisis. This year's plan was built largely on what we produced last year. You'll remember that last year we convened 2 full-day sessions to inform the direction of the plan, which is organized around Governor Hogan's policy priorities of prevention and education, enforcement and public safety, and treatment and recovery. We're grateful for the feedback and the insight that the IACC and our state and local partners provided into last year's plan. We felt that most of the goals and strategies that were identified last year remained a priority for the state as we continue to double down on our response efforts. The one new addition to this year's plan is the identification of our office's priority projects. These projects include developing a statewide infrastructure to respond to adverse childhood experiences, or ACEs, establishing a comprehensive crisis response system, developing wraparound services for people who are justice involved, expanding our network of recovery housing, expanding care coordination for people who use drugs and are seeking treatment, and utilizing data to inform programmatic decisions. As the Lieutenant Governor mentioned a moment ago, our data strategy includes the Data-Informed Overdose Risk Mitigation Initiative, or DORM, which formed out of the Chapter 211 legislation passed in 2018. The purpose of DORM is to link individual level data sets from opioid decedents to develop overdose risk profiles. These overdose risk profiles will help us target populations at greatest risk of overdose and will allow us to be more strategic in our allocation of resources. Beginning in January of this year, the OCC took over as the project director for the DORM initiative. In partnership with BHA, the OCC has developed a project plan that will guide the project as we move forward. And we are very grateful for the support of the Lieutenant Governor and the administration for prioritizing this project. And we look forward to sharing the findings from the first DORM report once it's released this summer. Next, I wanted to mention progress that has been made on the State Integrated Health Improvement Strategy, or SIHIS. SIHIS is an agreement between the state of Maryland and the Centers for Medicare and Medicaid Innovation, CMMI, and is an important component of Maryland's total cost of care model. The SIHIS aligns statewide efforts across 3 domains that are interrelated and, if addressed successfully, have the potential to make significant improvement in not just Maryland's healthcare system, but in the health outcomes of Marylanders. The 3 domains are hospital quality, care transformation across the system, and total population health. Addressing opioids was identified as one of the state's 3 total population health priorities. The other 2 are diabetes and maternal and child health. The OCC helped establish an advisory work group to inform the state's opioid-related goals, measures, milestones, and targets for the SIHIS application. And I'm pleased to report that the application was recently approved by the Centers for Medicare and Medicaid. Through feedback provided by our advisory group, the state identified improving overdose mortality as compared to a cohort of other states with similar overdose characteristics as its overarching SIHIS goal. While we were disappointed by the increase in overdose fatalities experienced in 2020, we believe the state has developed a comprehensive framework to reverse these trends, which will help us achieve our SIHIS goals. To ensure that the state is making progress as it relates to SIHIS, the Maryland Department of Health has established the Population Health Management Group, comprised of public and private partners, to advise on the implementation of strategies and interventions to support each of the 3 population health domains. We're pleased to be participating in these meetings, and we'll update this group with information pertaining to SIHIS implementation as relevant from time to time. So as I wrap up, I'd like to mention that the OOCC's call for proposals for FY22 funding closes this Friday. Last year, we received about 90 applications from governmental and private partners. We look forward to reviewing the applications that are received this year. We'll be glad to award funding to programs that are doing incredible work to address the opioid and substance disorder crisis here in Maryland. That concludes my update. Lieutenant Governor, back to you.
Thank you, Executive Director Hsu. Before we get to Dr. Brathwaite, just a question. Maybe this is something for Dr. Jones. This is very anecdotal, but just sharing something. My wife's nephew just passed away from an overdose. He's in San Diego. I want to say he's 37 years old, or was 37 years old. And, he was, living not the best of all lives. But the people he was with when he overdosed, or who came upon him, at least the stories are kind of shady, is that they gave him cocaine to try to revive him. And it seems as though, and what folks were telling us and through the family, that this is what these people, the kids think, or not kids, but they think because it's a stimulant they don't have naloxone, that they think it may revive someone. Now, maybe they're thinking that it's not full-blown overdose or whatever the case may be, but I don't know if anyone is hearing this kind of thing going on in the street world, but that was the first time I had heard of anyone trying to use cocaine to revive it. And as we know, the cocaine could very well have had fentanyl in it itself. So, I don't know if anyone has heard any of this type of thing, taking place or circulating.
In my years of practice, I've never heard of people using cocaine to try to reverse an opioid overdose. However, I will say that people do what they do the best that they can with what limited information it is that they have. So, but no, that certainly is not something that I can't recall ever hearing people trying to use cocaine to
Yeah, I was surprised to hear that, and then and my response was, you don't know if that cocaine actually has fentanyl in it, because that's now the primary mixture with fentanyl. It's not heroin, it's cocaine. So okay, all right. I thought I'd just share that. Well, thank you. I know we're going to get an update now from Dr. Brathwaite. Good to see you, sir.
Good to see you too. Thank you, and allow me to share my screen with you. I hope that I'm able to get this technology work as I would like it to. That's one of the things that is a challenge for me. So, can you see my screen?
Not yet.
Can you see my screen?
Not yet.
No, not yet.
Yeah.
Doctor, if you'd like to send your slides to Michael Corey, Coury, he'd be, I'm sure, happy to put it on the screen for you.
I thought that was...
Thank you, Director Shu. This is Heather. We also have it, sir. We can present.
Okay, go ahead, Heather. There we go. Are you ready, Heather?
We are ready, sir.
Okay. Well, thank you for the opportunity to share where we are relative to our program. Next slide, please. Slide 1. Slide 2. This task force has a, are you showing the slide, Heather?
She has the mission.
I can't see it here. So I'm not sure.
You're not seeing it? I'm seeing it on this end. It
Okay.
starts with Racial Disparities Task Force mission, :
I'm not seeing it. Thank you. So our mission is to, and I think the Lieutenant Governor alluded to the mission of investigating contributing factors and proposing and recommended solutions. And these are designed to eliminate the racial disparities related to overdose fatalities in the Black community. Next slide, please. Our task force update consists of 3 things. We have finalized the membership. We have also finalized the goals. And the 3rd thing is that we have hosted 2 task force meetings. Next slide, please. Our membership, as you will see, is a diverse group of both from the public sector and the private sector, and is an interesting group, as is indicated by the areas of specialization and emphasis, and also the experiences with drugs. Next slide, please. There are 4 goals of our task force, and one goal is to identify focused data-informed interventions, programs, and policies. as well as seek out innovative pilot emerging projects that will reduce the disparity in overdose fatalities in the Black community, which has been showing escalating rates of death despite statewide interventions. You see goal number 2, then I go down to goal number 3. Goal number 3, to determine how to increase acceptance of evidence-based practices for opioid use disorders in affected communities using a tailored approach. And the 4th goal, considering historical inequities, ensure equitable allocation of resources to combat the opioid epidemic. So those are the 4 goals that would guide and inform our task force. Next slide. We have had a couple of meetings. The full task force met first in February and April. At the April meeting, we provided additional educational opportunities for task force members. And that meeting included presentations on 4 areas. One was the non-stigmatizing language. And this is a call to use new types and forms of language. And number 2 presentation was on barriers to seeking treatment. The 3rd, we looked at harm reduction. And then we close off the session by looking at problem solving courts. Next slide. What are 2 deliverables that we have from the administration? One is to report to the Interagency Opioid Coordinating Council with a list of recommendations on programs and policies that could be implemented to address racial disparities related to overdose. And the second deliverable is that the first would be sometime around August 2022. Next slide, please. What are some of the next steps that we would be tasked with? One of the things that we have been looking at in the past, and we continue to look at this, would be the county level analysis. During our June meeting, we will be learning more about county-specific drug use trends and services gaps in the 4 jurisdictions where the largest racial disparities exist and where the largest number of African Americans are dying from overdose. So that's one thing that we will do at our June meeting. And we find that the 4 jurisdictions that are of interest with the largest number of deaths occurring are Baltimore City, Baltimore County, Anne Arundel County, and Prince George's County. During the June meeting, we are hoping to invite faculty from the Johns Hopkins Bloomberg School of Public Health and the University of Maryland to discuss findings from the statewide ethnographic assessment on drug use and services. This is known as SEADS, S-E-A-D-S, the SEADS study. And during that same meeting, we would be provided with information on further insights into county-specific trends, which will serve us as we conduct a fishbone analysis during our July meeting. So the June meeting and then the July meeting is going to deal with the fishbone analysis. And to those of you who might not be familiar with the fishbone analysis, it's worth saying that the fishbone analysis is to help us dig deeper into specific continuing factors influencing racial disparities in overdose. So we have a deeper dive into the factors. The second thing about the fishbone analysis is that information gleaned from the fishbone analysis will inform the creation of various work groups, which will function as part of the larger task force. We haven't yet decided what number of work groups there would be, but this, I'm sure, will be reported when we have that information. And each work group will be tasked with continuing to gather information related to their specific area to inform the larger task force as we work toward compiling our list of recommendations that will be submitted to the IACC in August of 2022. That, Lieutenant Governor, is our brief report of what we are doing in the task force. Back to you.
Okay. And I know I caught part of it, but what is a fishbone analysis? It makes me think of, getting a small fishbone stuck in your throat or something like that,
Dr. Joseph.
A fishbone analysis is just a way of doing a brainstorming activity where you're looking at root causes. So you have the different, the larger bones of the fish are the root cause, and then the contributing factors are the smaller bones of the fish. So it's just a way of collecting, collecting information from a brainstorming exercise.
Okay, the parts that get caught in your throat when you don't clean it. Okay, all right. There was something that caught my attention when I was reading through the minutes, and it's something we talked about before in terms of the racial disparities, is that on page 3, problems with opioids by age group and race, is that whites account for 1/2 of the individuals overdose in the 12 to 25 and the 26 to 49 age groups that are in treatment or part of the treatment population. So they're disproportionate in terms of overdose deaths in the younger age groups, whereas African Americans in the older age groups. And it kind of goes back to, at least my theory, is that particularly when you look at a place like Baltimore, Baltimore has an older heroin user population, a population that was using heroin before fentanyl came along. And maybe in the white population, it's a lot more than what I call the new opioid users that came off of the prescription medications, or, as maybe some young people were playing with prescription medications, never were prescribed, and then turned to heroin. I don't know if that theory is anywhere near correct, but the older African Americans, I'm just guessing without doing a survey, are longer term heroin users that are now dying from the combination of fentanyl, and your body just starts to break down as you get older.
Yes, that is definitely the case. And I think that the story here is why is it that African Americans don't enter into treatment in larger numbers when they're younger, so that they can kick the habit or go into recovery when their bodies are stronger, and therefore they're not still using the same amount or more of opiates when they're older, and their bodies are less able to tolerate the amount of substance. So that's really where the why that becomes significant.
Right, but it also means the strategy of going after those individuals is different than it would be for a shorter term user and addict, I would think.
Well, it means that, and it also means when we're designing our programming, are we targeting only one audience? Are we presuming that the needs of a person who's 30 are the same as the needs of a person who's 50 or 60? And the answer is no. But if we're not taking those things into consideration, then what it is that we're designing is a system that doesn't work well for the demographic, for all the demographics that need help.
Yeah. Okay. All right. Thank you. Okay. And all right. We also have today guests from Calvert County who are joining us to, join us to talk about the county's integrated mobile crisis response. And I think I had an opportunity to discuss this with the county maybe 2 years ago now. 2020 kind of is often this other category. So everything now that, trying to remember places that I visited, it's now I have to discount 2020 because I didn't visit too many places at that time. But I believe I did have an opportunity to talk to some folks about their integrated mobile crisis response unit. And I know we have a Dr. Drew Fuller, Ms. Denise Dickerson and Jason Phelan available.
Good afternoon. And yes, Lieutenant Governor, I actually have some really wonderful and treasured pictures with you, with our van. Actually, it was at Tech Ops on the Eastern Shore that was able to customize our van.
Right.
I was going to slide them into the slideshow, but figured, you know, maybe we'd set that at the end. But yes, you are absolutely correct. And I'm grateful that you remember that. So my name's Denise Dickerson. I am the supervisor of Calvert Crisis Response. I am a licensed alcohol and drug counselor, as well as a professional counselor for mental health. I've been with the health department for over 16 years at this point. And this is one of our crowning achievements in my career. I'm joined here today with Jason Phelan.
Hello, my name is Jason Phelan. I am the supervisor of crisis response coordination here with Calvert County Behavioral Health. I have been with the health department in Calvert County for just under 8 years. We are also joined by Dr. Drew Fuller.
Hi, I'm Drew Fuller. I'm a board certified physician, certified in addiction medicine and emergency medicine. And I had the honor of working in Baltimore City in the Hopkins system for approximately 8 years before coming to Calvert County. And then I had the honor of working in Calvert County, the emergency department here for almost 10 years, and focusing on patient safety and emergency medicine. And then focused my career on the patient safety issue of our time, which was the opioid epidemic. And so I've been doing addiction medicine with the health department now for about 3 years and had the honor of being part of this great leadership team and moving this program forward.
So we're really grateful to have the opportunity to present our program to you. So if you give me just one moment. This one. Share and from beginning. Right. It's for you, Bill.
So I think we're all unfortunately aware of the increase in overdose deaths in Maryland and the nation. The nation's seen, I think, a 27% increase they reported today. And then the Maryland increase should, I think, be adjusted downward to 17%, or is it 12%? But fortunately in Calvert, we saw a decrease over the last year of over nearly 20%. And that was perpetuated throughout the last 3 years as well. So Calvert County, we are 100,000 population. We have one hospital. The health department serves as the hub for our hub and spoke model, and we have approximately 500 opioid use disorder patients under care. We attempt to reach out to the community, as many of our counties do, and promote the overdoses to help gain awareness. And we understand there is some benefit to it, but we wanted to do more.
And before the implementation of our progressive model, we followed the same common SUD engagement models as most practices. And these common models lead to common barriers in care, which include delays, looking for complete assessment appointment slots, restricted processes. And the problem with that is that people were dying while waiting for treatment. So we decided, what more could we do? In 2017, before the implementation of this program, it took about 2 weeks for clients to see a medical provider when coming in for services. And that was just too long of a wait. Through grant funding, we were able to get a couple more providers who were X-waivered, and we launched the Recovery Rapid Response Program, getting that wait time down to 2 days. We still figured we could do more. And with funding from OOCC, we were able to get our mobile unit, bringing that wait time down to 20 minutes. And finally, in 2021, with Calvert Crisis Response, we are now 24/7 on demand. Our on-demand model includes immediate brief evaluations, early access to medications for opiate use disorder. We're client-centered. We have those expanded hours. We have close follow-up appointments after initial engagement. We offer case management and additional services. This is just a workflow of what our current model looks like. The client is seen for a very brief assessment. If needed, they receive medications. Within 48 hours, we try to get them in for that full assessment and link them to other services.
And we know treatment is certainly critical, and bringing access to care is where we want to lower those barriers. And so we have a headquarters in the health department building. So we feel that it is important to have office-based care, but we wanted to go out into the community and reach people that weren't able to make it into our 4 locations throughout the county. And thus, through the grant through the OOCC, we're able to purchase this van and are now able to meet people in the woods, meet people in a parking lot, go into their homes, treat people in the basements of the house or wherever is needed. So the model is, it's a prompt medical model, and we go out and we do some lecturing because we find that we believe we've made some success, but we don't want to be stuck in a silo. And so we've been reaching out to other communities and stakeholders about sharing our model. And we think it should be target assessments with rapid access to medications. And so in order to help educate others into the medical model of addiction care, we try to use asthma as the metaphor. And as an emergency physician, if someone came in with an asthma attack, I would treat their asthma. And then we would refer them to help get to the roots of their asthma. And so that's the metaphor that we try to get across to other behavioral health and mental health providers. Treatment first, and then dig into the sources later, and then complete services as they're obtainable. And we understand that early medications is key to success. There's lots of evidence for this, whether it's in an emergency department or whether you can transfer that model out into a clinic, that if you can get someone a dose of medication as soon as possible, it can double the chance that they'll follow up for subsequent visits. We do have medications on site in the health department, only not on the van, but on site in the health department. If someone is in acute withdrawal or has an acute need, otherwise we can prescribe them medications electronically. We have a very rigorous system with an induction guide and for our clinicians, but if we don't give medications on site and provide them for the patient to take it home with a prescription, home inductions are certainly become a standard, and we help guide them through that very challenging process. And I will say, one of the biggest barriers that we are seeing now for people getting onto buprenorphine, which we believe is a gold standard therapy, is that fentanyl is so difficult to come off of, and then buprenorphine precipitated withdrawal is a challenge. We find that it's critical to give our patients a lot of guidance on how to start the buprenorphine. But with the medications that we have on site, we have a very rigorous security process through tracking from cradle to grave, every pill that comes in, and we have a rigorous storage system as well. And it's modeled after what's done in the EMS world.
So our mobile crisis team was born out of the opioid crisis, and again through funds with the OOCC. That it's our pride and joy, and it's really opened up doors for us to be able to go out and treat individuals literally where they are. So each team consists of 3 individuals. So we have a peer recovery specialist, a licensed therapist, and a medical provider, whether in the form of a physician or nurse practitioner or a nurse that can help gather the vital medical information and facilitate telehealth. And literally, like I said, we're meeting them where they are. And if you've had the chance to come to Calvert, we've got woods, we've got beaches, we've been pretty much everywhere. So our van, again, was customized by Tech Ops over on the Eastern Shore, and there's some things that are very specific to it. We have 2 clinical rooms. All of these chairs actually move, tilt, lay back, turn around. It allows for having a really nice conversation area so that it doesn't feel as clinical. But there's also 2 rooms to allow for seeing more than one person at a time, as well as a door that helps to provide some privacy. We have some specialized features that also help with doing treatment as well as outreach events, including the awning and a generator with a separate HVAC system in order to keep the air moving, which has actually been a really helpful thing with COVID. And then labeling was something that was incredibly important. We wanted to be present, but not present. So it's easy to put just a label on the side, but not have to have a huge descriptor on there. So we can tell people, hey, look for the big white van that has MCT versus your neighbors knowing that this is a mobile crisis treatment or emergency services. So discreet, but not discreet.
And activation of the team. By reaching out to Calvert County Emergency Services and Communications, we were able to link with them on being activated on 911 calls. So as a 911 call comes in, we're actually activated in real time with fire, EMS, and police to situations of crisis in the community. We also have a dedicated hotline number that any community member can call at any given time during the day that dials directly to 3 of our staff members on shift that day. We do have emergency communication issued EMS radios, as well as being linked to their account on active 911, which gives brief descriptions of the crisis calls coming in. Scene interaction. When we arrive on scene, we stage back until the scene is secured. When that scene is secured, we approach first responders and see how we can consult and collaborate with the first responders. We are not there to dictate or guide what's going to happen with individuals in crisis. We are there simply to offer our services if appropriate.
And then some of those services include not only the targeted assessment of the person, but once again, as I mentioned, if they do need medications and they're post-overdose and they're stable and can come with us, or they have an other opioid crisis, we can do that assessment. And then the provider, be it the nurse practitioner or the physician, can actually write a prescription and send it to a local pharmacy. If they do not have transportation to the pharmacy, we can actually, there's a seat in the back, we can bring them to the pharmacy. And if it's after hours or if they don't have funding, we can actually bring them back to our headquarter office and provide them medication if needed. Once again, we only do mobile prescribing. We do not do mobile administration of buprenorphine. And while we're extremely grateful for the state agencies and DEA for helping us investigate whether we could do this or not, and we had approval by the state agency, the OCSA, the DEA does not have a provision that allows for mobile administration of buprenorphine outside of veterinarians and EMS. So we're striving to get programs such as ours classified as a specialty EMS designation, and we've put those comments into the federal registry, but we'll see what happens with future regulations. And then one of the things we find that's absolutely critical to what we do is not only that we're on board and that we're trying to build awareness, that our community and stakeholder engagement. And so the messages are critical. So everyone and anyone is vulnerable. And we talk not just about stats, but we try to show it's about real people, and it's real people in our community that are dying, and they're young people with children that are dying on a regular basis. And so this helps us really try to combat that stigma, and it's the stigma against the disease, it's a stigma against the people, but there's really a lot of stigma even against the treatments that we're trying to combat. So we try to provide education in a holistic way.
So part of the ways that we started working on collaborating and developing stakeholders were reaching out to leadership, including MIMS. And this is a letter of support that we received from MIMS, helping us with providing protocols to our local fire and EMS in regards to being able to actually transition individuals that are deemed stable by certain medical criteria that are declining to go to the hospital to our mobile crisis team to be able to be seen at that point. And to EMS and fire and law enforcement, you know, ultimately the goals that we have in our messaging is that we really want to improve the patient engagement, decrease the amount of times that they're going out to the same individuals over and over again with opioid related issues, mental health related issues, and optimizing our resources. Calvert County is primarily a volunteer fire and EMS body down here. So the more that we can optimize those resources and utilize us for the things that don't require that immediate medical treatment, allows for those individuals to be present for other issues. We've done outreach to Calvert County Sheriff's Office. We've attended their roll calls and answered questions regarding our program, given them some education in regards to compassion fatigue, the services that we have available. We did ride-alongs with Calvert Advanced Life Support, our paramedic unit, and they were integral in helping us to develop some of the protocols and providing guidance and feedback. The Calvert County Health Department is actually in the same parking lot as the only hospital in Calvert, and we have a very important and vital relationship with their emergency department. We have a peer recovery program within Calvert County Behavioral Health that has a dedicated peer to the hospital. But after hours, the hospital can contact the mobile crisis team to come in and see those individuals as they're being released from the emergency department to provide that ongoing care and schedule those next appointments. And a lot of this is addressing compassion fatigue, specifically when we're dealing with the COVID crisis, because not only are we dealing with the everyday crises these individuals and first responders are experiencing, but now we add another epidemic and crisis on top of that. So it's really something that we're looking at to kind of help our community, not only in going out to the scenes of these crises, but helping our first responders. Other partnerships that we've developed with local and regional residential programs. We've met with our outpatient treatment providers in the area, as well as a number of community-based advocacy groups. We do a lot of outreach with all of these partners in regards to doing education, getting the word out that if these agencies are closed or if you can't get a hold of someone, there's always going to be the safety net of this 24/7 program. And one last partnership is with Safe Nights. This is a program within local churches where they provide shelter for our homeless population during the winter hours, or I'm sorry, during the winter months. So this is another partnership where we go out and do outreach, scheduled outreach, but also provide them with information that if they do have an individual come in that is in need of immediate services, that we can come out and see them.
And then community outreach. When we first launched this program, we were going out to neighborhood watch meetings, other sort of small meetings, and a gentleman came up to me afterwards and said, wow, this is the best kept secret in Calvert County. And that hit really hard because that's not what we want to be at all. We don't want to be a secret. We want the population to know that we are here for them. So what we did, we helped spread the word. We have window clings that we're giving out to businesses and community members. We have business cards for referral directly to our team with that hotline number on it. We also have pushed out an advertising campaign, which includes a billboard on our major thoroughfare in Calvert County, as well as a television commercial, radio ads, and publications in local media.
And we recognize that this absolutely would not be possible if it weren't for SWORD grants and the OOCC helping funding us early on, the Maryland Department of Health. We've had a lot of great collaborators. Tim Chismar at MIMS, Lisa Guy at OCSA was absolutely instrumental in helping us move forward. And then we have a lot of leadership in the county level as well. But even the DEA and the branch office in Baltimore and the national office was very helpful in helping us strive to move forward. And then we even other regional stakeholders with the hospital and the CEO, Dean Teague, and Dr. DeBoulis of the emergency department of really helping us form these alliances and move forward. So without them, we couldn't have gotten this done. And then, but we do understand, and as we mentioned, that COVID has taken a huge toll on us. We're hoping to continue to increase the access to care and beat down the increases that could potentially happen. But we understand it's not just about a single line of treatment. It's a comprehensive approach. It's about harm reduction. It's about prevention, and it's about treatment.
And here's some engagement stats for you from July of 2020 till March of this year. We've had 334 consented encounters, and these aren't technically treatment encounters, but this is where our team has gone out and offered resources, some sort of engagement. While most of those encounters have happened in the office, the mobile van is still a crucial component of what we're trying to do here. We've had 204 actual treatment encounters with an initial follow-up rate of 87% and a retention of care rate of 74% after 6 months.
And note, I'm sorry to jump in, no, but this is a very high-risk population, which are the least likely to actually follow up. So we have to, if you have to send a mobile unit out to go get someone, they are the sickest of the sick. And the fact that we have this success in treatment retention, we find that is remarkable so far.
those stats are something that we're incredibly proud of. I think that that's something that we can point to where we feel that we've definitely had an impact, and having contact with individuals in that moment of crisis to be able to bring them back into the office for follow-up care within 48 hours. And that's kind of our threshold. We like to have someone in within 48 hours to ensure that dosing is correct, that we can make sure that the crisis has passed and things are stabilized. So those are things that we're incredibly proud of. And I think our retention rate really speaks of that. We do want to point out that we did, prior to February of 2021, we were not 24 hours. So February 1st, we actually went 24 hours, and we expanded our availability to public safety in regards to the types of calls that we could be dispatched on. After doing some research. So I think that our numbers for the next fiscal year will look drastically different in regards to the number of encounters that were done on the mobile unit versus in the office. And I think COVID also played a major role on that. So our key takeaway points are really the treatment on demand model. By bringing in individuals and capturing the information that's absolutely necessary in that moment in time to get somebody stabilized, to get them access to care, to get them access to substance use medication, that allows us to get someone stable so that we can have a further conversation about what else can we do for you. And that's literally the question we ask each time is, what more can we do? What more can we do to help break down barriers? What more can we do to get individuals closer to treatment? And that's, again, going from that brief assessment and then worrying about getting the comprehensive one later on. The expanded access, being able to go 24/7 and have full teams available at that time, either to go out into the community to answer phones. A lot of the phone calls that come in are just basic questions, asking for information. How do I access services? When do I start taking buprenorphine? How do I avoid buprenorphine precipitated withdrawal? COVID actually expanded our ability to look at things such as telehealth for individuals that may not necessarily want us to come out, but may not necessarily want to come in. So we've really had a chance to kind of push beyond our boundaries and look at new ways to solve really difficult problems. And we've gotten very creative with this. Our team component being 3 individuals, you have a peer, a therapist, and a medical provider. And there are times where we're not acting in our exact roles, but you're just being present or providing support because at that moment, someone might need a peer to talk to them about real life experience, or you may need a therapist to do a risk assessment or a doc to give meds. And then we would really just not be anywhere close to where we are right now if we didn't have that stakeholder collaboration. Our partnerships with our community, we're lucky to have had good relationships before. Those partnerships are even stronger and even better. And we have fairly open lines of communication for constant feedback because, I mean, this is uncharted territories. None of us really knew what we were doing when we kind of started putting this stuff together, and the things that are working, we're continuing to try to make better. And this is a reference from an earlier slide, I believe, in regards to the MAT. And then our contact information.
Well, thank you. Thank you very much. Denise, I thought you were going to include a picture that we took, but
Thought about it.
okay. Thank you very much. When you mentioned the amount of engagements and then you said the non-treatment engagements, and then it was 200 and some number of treatment engagements. Was that, how was that split between the mobile crisis vehicle and office? Or was that all through the mobile crisis?
I think the initial engagements, there was approximately 300 and some. The majority of those were in the office, and those were stats that were started in July of 2020 through now. What we found is individuals were very concerned about us coming out and seeing them in the van during COVID just because of the close quarters. That we ended up getting pretty creative and seeing individuals at community areas and parks, outdoors, places where we could kind of figure out how to help protect confidentiality. In addition, I think that being able to go 24/7 has allowed us to have greater access in the evening hours where we're using the mobile component lines.
And then telehealth also. So we were able to reach out to people throughout the county on telehealth, and we had found that as an office visit directly, but we were even reaching out to people in other counties. And in fact, I did a call with someone that was in an emergency department at a neighboring county and it followed up with us. So telehealth really allowed us to gain access. And we do serve PG County, St. Mary's County, and Anne Arundel County in the borderline regions.
Right.
The ban does not, by the way, the ban does not leave Calvert County.
Okay. You had mentioned also fentanyl and buprenorphine. Is it that it's just not as strong, or what's the issue there?
So buprenorphine has really become one of the gold standards for treating opioid use disorder. The challenge with fentanyl is that the fentanyl is so strong and can be so lasting in people's bodies, it dissolves into fat cells, that the period of time that they have to wait until they're in enough withdrawal to start the buprenorphine can be hard for some people. Buprenorphine will actually go in and kick the heroin and the fentanyl off the receptor, but it won't stimulate the receptor as strongly. So if the receptor is too saturated with fentanyl or heroin at the time, it can cause withdrawal. So you have to time the buprenorphine. But once you get them on it, it's fantastic medication.
Okay. Now, and also then maybe our last question, I'll let others ask questions. There was some mention about veterinarians can do mobile buprenorphine. What is the ailment that the animals have that they need buprenorphine?
I should have, thank you. I should have clarified that. So buprenorphine was originally developed back in the 70s as a postoperative pain medication. And then it was found to have a lot of use in animals. So it's the primary pain medication for veterinarians.
Oh, okay.
Veterinarians do mobile care. They have a specific act by Congress that allows them to do mobile care with buprenorphine.
Interesting. Okay.
These were interesting.
Did not know that. Did not know that.
Extremely safe for 10-pound chihuahuas, extremely safe for 100-pound adults. So,
okay. Yeah. All right. Was not aware of that. Okay. Well, thank you all. Thank you very much. Any questions from any members of the coordinating council? Steve?
Yes, I just wanted to make a comment. We've been working very closely with Calvert County for several years, and the progress the county has made is really incredible. I would say that no one really thought that Calvert County's programming was where anyone would like it to be 4 or 5 years ago. We monitor 141 local level programs in each of the counties across the state to assess the extent to which those programs have been implemented. And of course, our strategy is that those 141 services will be available in one way or another to every citizen of the state. Calvert County now has 127 of those 141 programs in the county. 90% of that programming is in the county. And I don't know the exact number 4 or 5 years ago, but it was nowhere near that. So this team deserves an immense congratulations. And in particular, the progress they've made in the area of crisis response, where they were at ground zero not so long ago, to be where they are today among the leaders in the state is rather extraordinary. So congratulations to you and your team.
Thank you very much.
Thank you so much.
Okay. All right. Well, thanks again for that presentation. And hopefully it won't take another year before I can get out to visit with you. I should be able to do that, sometime soon.
Absolutely. We look forward to it. We'll send you a t-shirt.
Okay. But we'll contact your office and make arrangements to come down and see you. So thanks again. Okay. I want to thank all the presenters today. for what they were able to share with us, and thank everyone for their patience and listening to some of my questions from the uneducated. But I do want to just point out that our next meeting will be Tuesday, July 27th at 2 p.m. And with that, again, thank everyone, all the presenters, but also our council members and others who were able to join us this afternoon. Take care, everyone, and stay safe.